Let's talk about headache. So, what do you understand by headache? So, pain that is perceived from this portion, this temporal portion, this vortex, this occipital part, we call headache, right? We do not call pain perceived from this part, sinus or tooth or ear. We do not call headache. This we called facial pain. But this portion we call headache. But do you know, even if patient has maxillary sinusitis, let's say patient has chronic maxillary sinusitis, and patient might describe that I have pain here, I have headache. So how does it occur? So actually he may not have any intracranial pathology or no primary headache syndrome, but just he had chronic maxillary sinusitis. He will describe I have temporal headache. To understand that, you have to understand the pain fibers, how it travels, like these trigeminal nerve fibers that innervates facial structures, ophthalmic, maxillary, mandibular division. This is innervating these facial structures, and the pain is carried from the sinus, from the tooth, from the external ear with these trigeminal nerve fibers. And when they go to the trigeminal nucleus, there they converge, right? So the pain that is coming from the sinus gets converged with the nerve fibers that is coming from the temporal portion. So the brain cannot distinguish whether the pathology is here or pathology is here. This is called shared nerve pathway. The nerve, somatic nerve that is picking harmful stimulus from this person, and this person gets converged, shared. And so if the pathology is here but patient will describe symptom here, if pathology in the teeth but patient will describe headache, because of this shared nerve pathway. That's why many physicians go on treating as primary headache syndromes, but pathology is elsewhere. Maybe chronic sinusitis patient has, right? So we have to do detailed physical examination and detailed history. History is mainly required to distinguish primary headache syndromes, type of primary headache syndrome, but physical examination, at least this structure is must. Sinus, palpation of sinus, examination of tooth, examination of external ear canal, refractory error, fundoscopy to look for raised ICP, papilledema, focal neurological deficits. You can examine eye movement, facial symmetry, tongue deviation, power of limb, whether there is hemiparesis or not. We rule out basically secondary causes of headache. Then when we rule out those, then we can think of primary headache syndromes. But we have to be very careful in ruling out secondary headache, because whatever I told you, these are not the only things. There are many other things, like you have to look for fever, neck stiffness, weight loss, whether there is a new onset headache in the elderly that suggests some intracranial pathology, weight loss, new onset headache, or if patient has chronic headache, then there is change in the character of headache that also alerts you to some intracranial pathology. So these are some of the points, and you can also examine by asking patient to cough, whether headache gets aggravated with cough or not, or with Valsalva. If it gets aggravated, then that suggests there is high increased intracranial pressure. Now let's come to primary headache syndromes. So if you see the headache classification, there is a long list of primary headache, but we won't discuss those. We will only discuss whatever we use in our clinical practice most often as internist, not as a neurologist. So most commonly the terms that we use are tension type headache, migraine, cluster headache, trigeminal neuralgia, short acting unilateral neuralgiform attack with conjunctival injection and tearing. Long name, right? Short acting unilateral neuralgiformic headache with conjunctival injection and tearing. So if you see these primary headaches, their pathophysiology overlaps. This is not a distinct entity that you can separate. Their pathophysiology overlaps. And what is the underlying pathophysiology? I am telling you from internist perspective. I am not telling you from neurologist perspective. I am just wanting to simplify things, right? So what is the pathophysiology of headache? So one is inflammation. There is neurogenic inflammation with the molecule called calcitonin gene related peptide. This CGRP molecule mediates nerve inflammation. There is one inflammatory component. Next is vasodilatation component. You know, our internal carotid artery supplies the blood inside the cerebrum, right? Those cerebral circulation. In those blood vessels, if those blood vessels dilate, and when their dilatation occurs, what happens that the nerve fibers that is on the wall gets irritated, and those convey pain signals to the somatosensory cortex, and somatosensory cortex interprets it as headache, like pain coming from here, right? So one is vasodilatation. Other is trigeminal nucleus activation. So in how that trigeminal nucleus gets activated? In primary headache. This is not clear, but anyhow, due to some trigger, this trigeminal nerve or its branches like maxillary, mandibular, ophthalmic, this gets irritated, and this sends impulses, signals to the somatosensory cortex. And you know, when these pain fibers are traveling through this trigeminal nucleus to the thalamus, which is a relay station from where the pain signals go to somatosensory cortex. Before that, there are some fibers that go to the hypothalamus, and you know, in hypothalamus there is autonomic center where there is regulation of autonomic activity. That's why there is a one distinct entity called trigeminal autonomic cephalgia. So there is trigeminal activation, and from that there is also autonomic symptoms, and cluster headache is one of the TAC, trigeminal autonomic cephalgia. So I discussed, like, one is CGRP related inflammation, another is vasodilatation, another is trigeminal nucleus activation, another is cortical spreading depression. So what does the name imply to you? Cortical spreading depression. So it is spreading in cortex, and it is causing depression of neuronal tissue. Like in seizure, what happens? There is excitation of the neuronal tissue. But here it is saying that in cortex there is a spread of depressing potential, depressing voltage, and it is slowly spreading, slow spreading cortical depression. Like when this impulse arises, let's say in the occipital cortex, it travels like 3 mm in 1 minute. It is so slow, it goes and spreading slowly, right? And when it spreads so slowly, there is slight activation. Activation means depolarization of the nerve fibers, and after that there it goes into refractoriness, and in refractory period it cannot be depolarized again. That's why we call depression, cortical spreading depression. And this theory of cortical spreading depression has been discussed with migraine. In migraine we discuss this theory. You know, in migraine there is sensitivity to light, sound. Why there is sensitivity? Because there is already some depolarization, and when there is slight, if you give slight extra stimulus, then there is hyperexcitability, and patient cannot tolerate bright light, noise. There is also nausea, you know. In nausea, vomiting can occur in migraine. Generally we get confused, like it might be increased ICP, but it can occur, nausea can occur in migraine. So why it occur? The same thing, that cortical spreading going to chemoreceptor trigger zone, stimulating that. Why does aura occur? That same cortical spreading depression traveling, stimulating the olfactory cortex, auditory cortex, visual cortex, right? So when those gets abnormally depolarized, abnormal voltage occurs, these kinds of symptoms occur even though there is no extra sensory stimulus, like there is no sound, but patient can perceive like there is some sound, like hallucinations. There is no smell in the surrounding, but patient can describe that there is burning, plastic burning smell. How it occurs? Because there is abnormal depolarization in the olfactory cortex. Patient can describe some taste sensation, even though he is not tasting anything, he can describe taste sensation. So it is a form of seizure, you can say, right? But it is slow seizure. Like in seizure, what happens? There is sudden hyperexcitability, and you get sudden motor symptoms, sudden sensory symptoms. But here is slow symptoms, because it is spreading slowly, so it lasts longer. You know, in migraine, symptoms can last for up to 3 days without remitting. Generally when migraine starts, it goes from 4 hours to 72 hours, and I think they have not described any migraine in the literature that is less than 4 hours. So why does this much time duration it takes? Because of this slow spreading depression, it takes long time, and there is inflammatory component. You know, inflammation takes some time to subside. It does not subside within 4 hours, right? It takes some time. So at least 4 hours it lasts when it starts, migraine. So I discussed cortical spreading depression also, right? And another theory is that there is occipital neuralgia. You know, there is this occipital nerve on the back side, which is branch of cervical spinal nerve C2, C3. When there is abnormal electrical potential in that nerve, I told you that this can be confused with tension headache, migraine, cluster headache, because you know these pain fibers are so complicated to understand. You know, these nerve, occipital nerve gets interacted in the trigeminal system with these nerves, right? So even this nerve is irritated, you will feel pain here, here, because of this shared nerve pathway. That's why even if you block this occipital nerve, your pain on this portion goes away. You have blocked this portion, but pain on this portion goes away. How it occurs? Because this trigeminal nerve fibers and this occipital nerve fibers share a common nucleus, and if they have shared the common nucleus, their neurotransmitters are shared. So even if you block this, pain from this portion goes away. That's why occipital nerve block, Botox injection are really helpful in curing headache. It can cure headache. It not cure permanently, but for 3 months, 6 months, patient does not require any medications. So good. So in migraine, I told you that various kinds of aura occur, and there can also be hemiplegia in migraine, like mimicking transient ischemic attack or a stroke. There can be sudden paralysis of the right side, left side. There can be sudden symptoms like Broca aphasia. You might have seen a news reporter, she was reporting news, suddenly her speech started blurring while she was reporting, and she saw abnormal jiggling sensation in front of her eye, and people thought that she might be having a stroke. They did imaging, and it was later proved to be migraine. So symptoms like Broca aphasia, symptoms like transient ischemic attack, a stroke can occur in migraine because of this cortical spreading. When it spreads to the motor cortex, it depresses that motor cortex, that cortical spreading depression, there can be paralysis. But it will resolve when that spreading depression will pass away in due course of time. It will resolve. Similarly, when it affects Broca's aphasia, that electrical activity, there can be problem. Patient cannot speak clearly, but when that electrical activity moves away, pass away, then patient symptoms improves. So it can be get confused, even a transient ischemic attack, stroke, right? So these are some of the pathophysiology. Some are still theory, those have not been explored detailedly. Scientists are still studying this theory, but these are some of the theory based on we prescribe treatments, right? Because we have to know from the perspectives of patient management rather than scientific perspective. Scientific perspective is very difficult to understand, and you can imagine how difficult it is to explore neurotransmitters at the level of the neurotransmitter level. I can't imagine that even. So in migraine, to abort the acute attack, we give vasoconstrictors like serotonin agonists, 5-HT3 agonists, sumatriptan, rizatriptan. These, what they do, they act acutely and constrict the blood vessels, and patient can feel acute relief because blood vessels has dilated, and these triptans, ditans act fast and constrict the vessels, and patient can get sudden relief of the symptoms. For preventive treatments, we use tricyclic antidepressants, SSRI, SNRI, beta blockers, right? In tension type headache, for preventive treatment, we use this TCA, SSRI, and for acute attack, we use NSAIDs, paracetamol, caffeine. In cluster headache, we use oxygen as to abort acute therapy. How does oxygen help? Oxygen also vasoconstrict. If you give oxygen, 100% oxygen, it does vasoconstriction of the vessels, and patient can get relief of symptom within minutes. You can also use triptans in cluster headache also, because these act acutely. To prevent further attack, we use verapamil. Verapamil is calcium channel blockers, like in AV node it blocks calcium channel blocker. Similarly, it blocks the calcium channels receptors in the nerve fibers of this trigeminal nerve system, and that also helps. But verapamil takes some time to act, like 3 to 4 days. So during that time period, if I don't think I told you, cluster headache occurs in clusters. Like when it occurs today, it can occur tomorrow, day after tomorrow, and like 3 to 4 days in a row, and it goes away for 1 year, 2 year, and again it occurs in the same time period, in the same time of the day. Like it occurred at 3 p.m, it will occur at 3 p.m. So diurnally fixed it is, right? So I actually forgot what I was trying to tell you. So it occurs in bouts. That's why we call it cluster headache, because it occurs in cluster. So let's say today, now I remembered. So let's say today patient has started the cluster attack, and you give verapamil. So it will take 4 days to act. So in the interim, you have to add something else so that patient can get relief. Like we add prednisolone for 5 to 7 days. So prednisolone also helps, because I told you there is inflammatory component as well in these types of primary headaches. So glucocorticoid, even we use glucocorticoid injection at the occipital nerve. Not only we use local anesthetics like lidocaine, bupivacaine, but even glucocorticoid injection if you give at the occipital nerve, that helps. Or even if you give systemically, I mean oral glucocorticoids, that helps in cluster headache.